Good evening everyone. My name is Anitha and I'm going to discuss about golden hour syndrome. Introduction: golden hour syndrome, also called as facio-auriculovertebral dysplasia. It was first described by Goldenar in 1952, later by Gorlin in 1963. It is a rare congenital disorder involving craniofacial anomalies. It is associated with vertebral, cardiac, renal and central nervous system defects. It is a classical triad of epibulbar dermoid, accessory auricular appendages and oral fistula. I am representing about 5 cases. First case is classical presentation of golden hour. A 6-year-old male baby presented with preauricular skin tags and swelling in left eye since birth. Birth history revealed mother of baby had gestational diabetes. On general examination, we can see facial asymmetry, mandibular hypoplasia and preauricular skin tags, unilateral hemifacial microsomia on the right side. Ocular examination, best corrected visual acuity is 6/6 in both eyes. In right eye, we can see in conjunctiva, temporal epibulbar dermoid 4 into 3 mm at 9 o'clock limbus. In cornea, central clear corneal peripheral encroachment. Right eye K1 is 42 and K2 is 45. Axis is 180 degrees. Fundus examination is normal. Management, surgical excision of limbal dermoid to prevent amblyopia and strabismus, especially in the pediatric group. Surgical excision of preauricular tags for the cosmetic purpose. For mandibular hypoplasia and hemicranial microsomia, it needs orthognathic surgery. This is a picture showing facial asymmetry and mandibular hypoplasia. This is the limbal dermoid with hair follicle. This is the preauricular tags. Case 2 is ocular predominant. 6 months old baby brought by his parents to the ophthalmology OPD with chief complaints of swelling in conjunctiva in the left eye since birth. History of consanguineous marriage is present. General examination, mid-facial asymmetry and preauricular skin tags on the left side. On ocular examination, left eye, conjunctiva temporal limbal dermoid 4 into 3 at 5 o'clock. Cornea, central clear peripheral 2 mm temporal encroachment. In left eye, K1 is 41.80, K2 is 45.20, axis is 180 degrees. Fundus examination is normal. This is the picture showing limbal dermoid and this is the preauricular tags. For limbal dermoid, we have to do observation, regular refraction and amblyopia prevention. Regular follow-up is required for every 3 months. For preauricular tags, if this is benign, no urgent intervention is required. Surgical excision done, later for cosmetic purposes. Advised ENT consultation to assess hearing and multidisciplinary evaluation. For case report 3, a 4-year-old female baby brought to the OPD with cheek complaints of preauricular tags and swelling in the left eye since birth. History of non-consanguineous marriage. In general examination, we can see facial asymmetry, mandibular hypoplasia, micrognathia, skin tag in the left cheek, preauricular tag in front of the left ear, kyphoscoliosis noted with concavity to the right side. Ocular examination, right eye 6/6 and left eye 6/6. And left eye conjunctiva, temporal limbal dermoid 4 into 5 mm at 5 o'clock and it is yellow in color with hair. In cornea, there is central clear peripheral 1 mm temporal encroachment. Left eye K1 is 42.60, K2 is 44.90, axis is 180 degrees. Fundus examination is normal. This is a picture showing, first picture showing facial asymmetry, micrognathia, preauricular tags, limbal dermoid and kyphoscoliosis with concavity to the right side. Surgical management is surgical excision of limbal dermoid to prevent amblyopia and strabismus, especially in the pediatric group. Surgical excision is required for preauricular tags and cheek tags. Hearing assessment, hypoplasia or hemifacial microsomia, it's needed orthognathic surgery. For kyphoscoliosis, bracing for mild cases, surgical correction if it is progressive, long-term physiotherapy and monitoring. Case 4 is 5-year-old male child brought to his parents with the complaint of swelling in conjunctiva since birth. Birth history is revealed mother of baby had a gestational diabetes. General examination, preauricular tags and asymmetry of face is noted. Ocular examination, right eye, in right eye we can see defect in upper lid, that is coloboma of upper eyelid is noted. In left eye, yellowish white elevated mass near the inferior temporal aspect of the limbus at 3 o'clock to 5 o'clock position encroaching onto the cornea, that is the limbal dermoid. In left eye, K1 is 41.25 and K2 is 44.95, axis is 90 degrees. And fundus examination is normal. Management is ocular management. Surgical excision of the limbal dermoid to prevent amblyopia and strabismus. Limbal stem cell and or conjunctival autografting techniques are being explored to reduce the recurrences. For lid coloboma, eyelid reconstruction is done. This is the picture showing bilateral preauricular tags and skin tags, limbal dermoid, and this is the picture showing lid coloboma. Fifth case is 5-year-old female child. Came with complaints of preauricular tags and conjunctival swelling in the left eye. Mild, on general examination, mild facial asymmetry is seen. Ocular examination, right eye is normal, left eye is yellowish white, elevated mass near the inferior temporal aspect of the limbus at 3 o'clock to 5 o'clock position and that encroaching onto the cornea. Left eye K1 is 41.25 and K2 is 43.95. Axis is 90 degrees. Fundus examination is normal. For ocular management, early diagnosis and surgical excision of limbal dermoid to prevent amblyopia and strabismus. This is the picture showing mild facial asymmetry and lid coloboma. Investigations, keratometry. Keratometry revealed 1.5 to 3 degrees differences in affected eyes. In fellow eyes within the normal limits. Fundus is normal in all the cases. Systemic investigations, cardiac evaluation, echocardiography is done and it is normal in all cases. Renal ultrasound is also normal. CNS involvement, microcephaly is present in the third case. ENT evaluation, there we can see preauricular attacks and no oral fistula. This is the comparison table of all the 5 cases. Discussion. Prevalence of golden hour syndrome ranging from 3,500 to 1:7,000 live births. Male is to female ratio is 3:2. Most cases are sporadic. Familial occurrence have also been observed. Etiopathogenesis, currently accepted theory states that this syndrome occurs due to the imbalance in cells during blastogenesis period. These are the derivatives due to the derivatives of first and second branchial arches. Ocular dermoids may lead to serious ophthalmic consequences like induced astigmatism, amblyopia and strabismus. Large size dermoids may obstruct the visual axis, causing limitation of the ocular motility or hindering eyelid closure, leading to exposure keratitis and corneal ulceration. Conclusion, prognosis for this condition is good in patients with no systemic complications. Management of golden hour syndrome requires long-term commitment with treatment spanning the child period of growth and development.